So, so this has been a very rich day. For one thing, I want to thank again the Planning Committee and particularly Terry, your leadership, and I want to make sure that we take this opportunity to thank the IOM staff. Just terrific in terms of the preparation of this day. We need to be thinking, I don't know about you, but my mind is so full with the new ideas and reactions to what we've heard today. And we have in the past really tried to involve everybody in this reaction, but I don't know that we're going to have time for that this afternoon. And so what I've asked Terry to do is really reflect a little bit first on what he's heard over the course of the day. Then I'm going to open the microphones to anybody who wishes to make a comment and in the reflective mode of what have we learned today, what lessons do we take from this very, very rich conversation. I know that there are people on the web who have sent in questions or comments, and I'm afraid that we're not going to be able to get to many of them. If at all, but if we have a few minutes at the back end, we may read some of those. So, Terry, why don't you go ahead and start?
Well, I won't go at the speed of a barker at an auction, but I'll try to move quickly. I've got a list of sort of ideas and things that I captured from a number of speakers, and certainly David set the scene. The one thing that stuck with me from what David offered was the idea that this roundtable should take the lead in determining what the total health budget is, to work on that as a concept. And that, you know, we're in this mode now where, as Jim talked about, moving from grant to grant, and when the grant expires, the dollars are gone. And David's comment that, you know, what if they had to have a bake sale to build a bomber? You know, we need to have a better model, a sustainable model. That's certainly a foregone fact. He talked about crop subsidies, mortgage interest deductions, Medicare medical education payments, ACOs, moving into foundations and the IOM's medical transaction proposals, a range of possibilities and ideas out there, and that we need to have a pay for population health performance system and a community health investment business model. Kevin told us that there are a number of hospitals in the whole community health needs assessment work, the need to collaborate across redundant health assessments that are occurring in the community, but that the hospitals, in terms of priority setting, could coordinate better, and there's a need to have clearer priority setting. And I think his concept of the idea from LA of a prevention trust with 1% of general operating funds from hospitals going into a prevention trust through an ordinance was a very interesting, sustainable idea that perhaps could be duplicated elsewhere. And he also talked about investment in low-income minority communities along with financial institutions to change the legacy of redlining, a real place-based focus, which was, I think, a theme that extended through the entire day. Gary talked about how you know, we need to focus on the streets where the charity care lives from the hospital perspective, because they will inevitably come to the hospital for care, to begin thinking differently about that approach, and that the payment system exacerbates the problems in the sense that paying for ED admissions and visits is certainly a big problem, and he called it a sort of, I think Gary called it a perversion of the system. Valerie talked about the efforts in conjunction with the San Francisco Health Department and how they've saved substantial money to the overall system. Perhaps, you know, that's a model where we're actually collecting data to determine where the savings are. Debbie told us the Nemours had some great reductions in ED admissions, 42%, I believe, that she talked about, also reduced to payments to hospitals in the process, which is part of the challenge that we just spoke of. I think that Raphael talked about and reminded us that we made great advances in health and housing, renewed attention to connecting community development efforts to public health metrics, and that the broader recognition across many communities and nationally of social determinants as drivers And it's interesting to me that community development agencies talk about social determinants. We talk about social determinants, but we don't always, as we say, common language, as Sani noted, the terms aren't the same. I learned that when we worked with lead and community development agencies. That was an issue. It took us a couple of years to understand each other, so we knew what each other, was smelling what each other was cooking in the process. So I think Don talked about grocery store financing, creating, in his idea of creating equity of access and equity of choice from the DFI perspective, not really thinking about changing behaviors and reducing obesity, but that may be an outcome ultimately from the work that went forward. And Nancy's one point that stuck with me is the mass transit and mixed use in proximity, showing an average of over 6 pounds of weight loss. And thinking about community design, I thought that was a very compelling statement from her. Megan shared with us sort of the big picture around the idea of paying for success, and we know that terminology around paying for success might be better than social impact bonds, depending on who you're talking to. I think it's important to recognize this, and I think that the nurse-family partnership model really stuck with me. That's something that public health can do right now, and that there appears to be great promise on that model to support based on the feasibility study, and she also impressed upon me the importance of feasibility studies. Bob said lots of things. And some of which I only have a very vague understanding of. But I think the most important thing you said that will stick with me is that the most important economic product is a ready-for-life 18-year-old, and what that means for the economic opportunity for a community. And the fact that the process is very detailed, over 18 months in terms of startup, lots of data to understand if this is a good investment for a funder. But I did feel after you and Rick talked that there will be opportunities where around asthma, perhaps, Rick, I think that that's happening all over the country, around nurse-family partnership, around what's happening in early childhood, where we will have an intervention that's been tested. It's been recognized as effective. And then we can, as Debbie has said a number of times, go to scale based on what is a strong enough evidence base. And I think we've really got to sort of ride those horses that seem to have promise, it seems to me. Rick talked about the asthma intervention in Fresno. He talked about the data from Boston in terms of reducing inpatient visits by 80%. That's compelling published data. And this idea of developing a portfolio of investable community health interventions. That should be something that this group can do as well. It seems to me that this roundtable could also work on that. Sani's point about saving money and improving health outcomes that we need to recognize from a healthcare and public health perspective, population health perspective, recognize that both of those are important. Jim talked about the need for a backbone organization, an integrator. Nancy called it a quarterback. Return on savings reinvested in a wellness fund. Jim and Kevin both talked about this. And enabling structures at the state and local level, Jim discussed, and Jeff talked about removing barriers at the federal level also is essential. The thing that stuck with me from Jeff's presentation was that those making social investments are likely to be agnostic about how or what they invest in. So public health needs to make its case and be willing to be held accountable. Not enough to just do good things. We've got to get in the game and be held accountable like everyone else. So those are the takeaway points that I've offered quite quickly, and I'll pass it back to George.
So let me offer a couple other comments. One, going back to the outline for David Kindig's presentation, he wanted to talk about the fact that to improve overall health and reduce or eliminate health disparities, significant and new reallocated resources of many kinds will be required. And we've talked a little bit about whether that's harvested from waste or where that come from, but we didn't really focus on that. And then we have obviously looked at other revenue streams that have different mechanisms, and I think that's quite exciting. The second point you made was, while philanthropic and public pilot funds are crucial for testing, developing and aligning dependable long-term revenue streams is essential. And I think we've seen some examples of some exciting different ways to think about that. This community and investment development investment discussion, and then the recent panel here, really is interesting because it changes the paradigm of reducing waste from taking away from somebody's rice bowl to creating an incentive or a profit for doing the same thing, which is very interesting. And the second thing I take from that is that the data discipline required for that is not what we typically think of in healthcare and health, but it's financial, and it's more of a project-focused, engineering sort of focus. I don't know if that's the right word or not, but a discipline to it. And I think there's much for us to learn about the relative deficiency of those skills within those who are currently responsible for geographic public health or healthcare, for that matter, and the ability to bring those skills together to turn around that discipline, that financing discipline, to something that's not a takeaway, but rather an incentive for people to figure out and step to the plate, figure out those. That to me is a very exciting sort of possibility that's opened by listening to this conversation today. We can start by reallocating savings from ineffective healthcare expenditures, but we'll need to expand health and all policy investments as well, especially by finding the sweet spots where core missions of other sectors align with health improvement objectives. And really to think of the sweet spot of how community investment organizations are thinking about some of these very same things and looking at these health effects as side effects or as not central to why they got into it. I think there's a tremendous opportunity for alignment and thinking about that there. But I also thought as we listened to those conversations that the interface between the public health, looking at the population, looking at the distribution of outcomes within a population, that perspective came into sharp contrast, let me put that, or intersection with the perspective that says, here's a particularly opportune situation from which we can make an improvement or a profit. And that difference between geographic, population-based analysis and the opportunity, I think that's really an opportunity for us to think through what that means, how to understand that, how to bring those perspectives together for a better benefit. New evidence is badly needed regarding relative cost effectiveness of different investments, but we can't wait decades to act, David said at the beginning of the morning. Well, maybe not, in the sense of those hallowed, trials, the hallowed trials, but maybe so as well. So what kind of evidence, and we ought to think through what the definition very carefully is of the evidence or the information that's needed to drive these change, or at least to motivate investment and trial and so forth. And that kind of opens that to a different way of thinking, almost a heretical way of thinking for many of us in terms of the gold standard of randomized clinical trials. And then the roundtable could act to add value by leading the call for the development of optimal cross-sectoral financial investment or policy strength benchmarks. We didn't really touch that at all. And one of the things that I thought was remarkable about the concluding panel was what it didn't say, which is we need data by geography, by function, that's much more robust and that can guide us to looking at the skew in terms of the differences in the performance of these different geographies that might be a guide to where a deeper look might be, engaged in to drive some performance investments. The public health aspect of describing the state of affairs in the country across all the jurisdictions still needs work. And it seems to me that one of the two things, that's one of the two kind of takeaways I take for our metrics discussion. But then the other takeaway I take for our metrics discussion is we need a whole new category of metrics that are around this financial discipline and actuarial discipline that helps us try to understand some of these other sorts of ways of looking at this. And so the last thing I'd say is that we have only scratched the surface in this research. And we've only, we really very carefully tried to set the table in terms of a broader spectrum of resources, and then we didn't touch whole categories of it. I think we've hardly touched this category in terms of other aspects of this that we could explore. So I think one of the challenges for the roundtable will be how to further develop a series of conversations and dialogues that help us understand this issue of resources relative to improving total population health. So those would be the comments that I would add to Terry's. We've had comments from the web, several, and one was a comment that from George Flores earlier in the day around we should not identify how to deal with policy and economic forces that will have a pushback. In other words, his comment I think relates to the fact that to overcome some of the pushback forces, there may need to be some change in attitudes in investors in Wall Street and others. And I apologize for the fact that this comes so late in the day, George, and probably out of context with what the comment we were trying to make. Bobby Milstein earlier in the day made the comment, many thanks for a terrific overview. When thinking about the prospect of setting benchmarks for health investment, how might we take into account trade-offs, for example, between short versus long-term impacts? And I think that reminds us that we need to be thinking about the range of impacts in terms of not just policy focus, but a longer-term sort of focus. Thank you, Bobby. I'm afraid again, sorry this comes so late in the day. And then a comment about quarterbacks and navigators that comment made during the Don Hinkle Brown, Nancy Andrews part of the discussion. Do you think public health agencies have the credibility to play these roles of quarterbacks in a community and or navigators? And if there is a role, how might these roles become regularly publicly funded roles? And so again, it kind of comes back to, I think, what was being summarized at the end of the day around what structures do we need, for these functions. And then maybe the last thing I'll say, because I've been thinking a little bit about my friend Avitas Donabedian, who wasn't really my friend, but he seems like that because he's been in my thinking almost my entire adult life and thinking about quality in terms of his structure, process, and outcome sort of framework. And it seems to me our thinking about effective community structures is at the structure sort of level. What kind of structure do we need for an integrator and so forth? I think we need to move beyond that to, which is an important question. And I think we need to move around that to what effective processes need to be in place and what key outcomes do we need to deliver. And that whole structure, process, outcome cascade needs to be tightly aligned and then disciplined by performance and outcome. So those would be a couple of my comments. So the rest of the roundtable, comments. The floor is now open for comments. What did you hear today? What do you want to say that in a reflective mode? Debbie.
Great what you guys did. Like many of you, I'm focused on action. So I'd like us to, it's a lot of information, but I'm hoping tomorrow that we can think through what are those things where we as a roundtable can add value. What can we lift up to? I think you mentioned this too, George. And what I really liked about the last panel was it was really focused on paying for value. It was really focused on value rather than, in the healthcare debate, it's a lot about costs and cutting payments, different ways to cut payments. But it was really about paying for value. And I also like the long-term nature, the way they approach things, right? Because that's another one of our issues, or not issues, but one of the things that I think are barriers with respect to the expected return on investment from, for example, CMMI with some of its early demonstrations. So I think in thinking about this, there are things that we can kind of lift up. Like I too grabbed onto the issue that I really think Jim and I have been talking about for some time, which is community capacity. What do communities need and what do entities need to move the ball forward? And what I'm hearing loud and clear in many different venues is a sophistication in understanding the data and costs, both the inputs and outputs, and being able to be very facile in doing that. And I don't think we have the infrastructures in place to do that. I think some of the managed care companies obviously have that. That's their business. But if we're going to start really focusing on value and moving the agenda, we need to build that capability, that capacity. So there's some quick.
Well, certainly as we convene tomorrow morning in closed session, the first thing we're going to do is try to harvest some of those specific ideas you're calling for. So you might think about that overnight. Other comments or reaction? John?
Yeah, hi, John Ebert, Mayo Clinic. So this has been a very interesting day. One of the things I'm struck with and trying to start to get my mind around is that one of the things that Donald said, he's told that a very interesting story, how he was trying to set up the grocery stores and sort of the food deserts, and then they published a report that it didn't decrease obesity rates, but that wasn't his primary goal. And it's sort of I'm sort of challenged, and it resonates with me because I'm coming from an addiction, from the addiction field, and similarly to some of the challenges we're having, addiction is held to a very high standard as well. Not only are we, if we're successful in getting the patient to stop smoking crack, we're also responsible for making sure they have affordable housing and they're off the streets. I mean, there's this very high, people don't go to a cardiologist and say, yeah, the cardiologist did a great job and I have a new valve, but they didn't, get me a new job and give me affordable housing. So I think addiction medicine and maybe some of the things that we're challenged with, because we do interface, socially when we're doing population health, that we're going to be held to these high standards. And I'm trying to get my mind around as we look for funders or investors or people that are going to be interested in our initiatives. How are we going to answer this tension between what are those outcomes that are going to be important health outcomes in terms of obesity and diabetes control and no smoking in the homes and clean indoor air, from these more proximal outcomes that are, while very relevant, might not be as sexy or cool or as exciting as those important health outcomes that we're all talking about in the news, but are very relevant in terms of food access, but not as exciting and not as big, out of the out of the gates exciting as obesity seems to be right now. So I'm really struggling with that as we try to lure investment in and try to get some of these things going. This is what I'm trying to get my mind around.
Maybe there's a role in that comment for us thinking about how to take what we heard today in terms of what we heard from the investors and turn it into a toolkit or a guide for how those of you who know about addiction medicine or other issues should think about putting together your data such that there's a coming together between the investment community and those who know this. I don't know if that's what you're suggesting, but the answer as to how to attract investors is, I think, beginning to think in terms of what investors need to know. That'd be one remark to that. David?
Sure. So I agree. We just scratched the surface, and I agree with Debbie that tomorrow and down the road we have to say what can this roundtable really do about that. That's our task. The thing I wanted to mention is what's all over my notes here. There were so many of these wild numbers thrown out today, and sort of about the health budget and health accounts. I mean, at least within healthcare, we know we spend 2.7 trillion, and that's probably more than we need, and the European countries are a little less than that. I mean, so 2.7 trillion and 500 billion. I mean, these resonate, but these numbers that are thrown out, like when Nancy said $100 billion is the shortfall that would be needed to stimulate from the private investing sector for work in housing and schools and childcare. I don't know. I mean, I've never heard that number before. I don't know if that's right or wrong or what's it all about. Or 1.5 billion in private investment can create $31 billion of social value, whatever that is. And then somebody else came on and said in the impact investing field, they thought there was $400 billion to $1 trillion waiting for something or other. So all I'm just saying is this whole set of numbers, those are all new to me. I don't know how to make sense out of them. I don't know how they apply to the health and all budget, the non-healthcare and public health part of what we need to do. But I at least am going to try to begin to get my mind around that, and I think that's a task we could do as well.
And once again, I think pursuing some of those individual comments that were made today in terms of trying to understand the individuals, why they made them, and whether that can lead to an analysis that would help us understand total resource needs or, some of these issues, I think might be a follow-up we may want to do in one form or another. Pamela?
While we still have our social impact or pay for success experts in the room, I realize that the piece of the loop that hadn't finished for me related to your comment, which was you reflected on David's long-term sustainable investments. So the part I'm missing in your loop, okay, so the investors come in, the intervention is wildly successful, it pays for itself, the government pays back the investors. And then is the government expected to continue to pay for that because they know it's a...
This is enormously interesting.
You're right. Yeah, please, thank you.
This is an enormously important question. Most of us who are in social impact finance see this in many respects as probably a self-extinguishing activity. That is, as soon as Salt Lake County realizes that it doesn't need to, that it understands the machinery, it understands the pre-K, it understands reduction of special ed cost, it understands that it can raise money by issuing bonds at 3% and doesn't need to pay Goldman Sachs 5%. It can do it on its own. So we would expect over time that many of these projects that are now being developed, explored, the research is being done by private and done by philanthropic entities. So there's a lot of philanthropic money being thrown at this, either personal or institutional. And then the initial demonstration projects have an interesting, capital stack. They have pure philanthropy, they have PRIs, they have pure loans, they have all of that's there. Every variety of philanthropic innovation is in these transactions. But, as I said, the state of South Carolina, when it sees that it can reduce neonatal intensive care costs, reduce infant health costs, and reduce child welfare referrals, which have their own set of costs, prosecutions, which have their own set of costs, add all this up together, they say, well, why should we pay social finance for this? So they just go ahead and do it. Now,
That'd be a good problem to have, certainly. It's down the road, but that would be a good problem to have from a community perspective, right?
Oh, yeah, absolutely. Now, I want to ask, it occurred to me, listening to you, that people who want to do this kind of work in the health area, and I guess maybe, Rick, you've already thought about this, but for me, how would we work with the public health community? I've never actually thought about that.
Well, I think, again, I was going to make, a comment here because I think there's a real area of opportunity that comes from this conversation, hence my comments about toolkits, hence my comments about the differences in data needs as we think about them traditionally from public health and healthcare. And your comment just reinforces that in terms of it being a self-extinguishing activity, which means there's something to be learned that could be in the public interest and in the value of the overall health that could be eventually done once you learn how to do it and establish it. And I know we're at the very front end of it at a much lower administrative burden than the first round. And I'm assuming I'm making an assumption here, so I'll test that with you. Would you agree?
Keep in mind too that we've had a criteria for our work to go where we add value, and I mean, this has been a great conversation, the best I've had, but the work that's going on at the San Francisco Fed with in some of this intersections between health and community development, I mean, that's a robust set of work too. So we need to be sure we are up on that and interact with those folks as we would go forward on where we add value.
And I think that's exactly right. But listen to the last panel in terms of their reaction to what they heard today, which was sort of, wow, So there's something for us to learn in terms of healthcare and public health about the discipline of how to evaluate these things from this perspective, I think. But that's one view. Anyway, other comments? I have to go around and call, embarrass people, or is it too late? Are there any additional comments or questions from the web, public comment? Is there a way we can ask for that? Anybody in the room who wants to come to a microphone and make a comment or ask a question who's not a member of the roundtable? I don't see anybody coming up. Jim, are you going to want to make an additional comment? Jim Hester, identify yourself.
Jim Hester. I just want to talk about the cumulative value of having this investment portfolio and having the community resource of the structure we're talking about. I mean, Rob's job would be so much easier if he had something like that kind of an organization to partner with in terms of putting it out. So in terms of identifying viable transactions, the presence of that kind of entity really increases the likelihood of being able to do that. But I also want to say there's something about that community structure will not be sharing in the savings unless it's a value add. And it has to, so it has to understand in what way can it provide value add to its partners that justifies its getting a share. And that's something we have a lot to learn about. And I think one of those could be there's a benefit of having multiple interventions occurring simultaneously that reinforce each other and have a cumulative effect so that your likelihood of success is enhanced by working and partnering with the organization. So it's not just a matter of one of things, looking at them all the time. It's saying, how do they fit together?
Jose and then Debbie.
Something that struck me in the different presentations, I'm still trying to figure out how to mix in my mind the discussions around hospitals' role and role of community benefits with all of these investments and the big difference in the perception of charity. And I think that was Rafael who said you cannot scale up charity, but we can with all of these other investment processes. How do we channel change the way that we fund those things at the hospital level toward this type of community investment? That requires huge legal tax reforms that I don't know who will be willing to even consider. But looking at outcomes, there is a clear difference. So can we build a mixed model that brings those things together? And what role in all of this does the traditional government-based public health plays as we move forward? I think that maybe it was Jeff. We risk being left behind. And none of us is in the financial world to really assess and look at this type of thing. So it really calls for a whole new type of partnership and thinking. We have been talking about the health department of the future, where we are not going to be doing X or we or B or Z, but then should we engage in this type of things, or is somebody else that quarterback? Is somebody else that lead integrator? I am a strong believer in the role of government. I don't necessarily believe that has to be a public health agency when we're talking about social development. But that's a discussion that we need to have somewhere, because we will not advance population health in a systematic, measurable way if we don't.
Yep.
Just to add, it was a comment to Jim, but also applies to what Jose is saying, that the integrator organization is going to look different in every community, because to the point that Jim was making, it's the idea is to add value, and so the functions are going to be different, and it may not be all in one place. So when you ask the question, Rob, about like who is public health, who do I talk to, it's going to vary depending on what the issue is and what's happening in that community. It's not going to be one entity, and I think we have to recognize that. And Jose, to your point about how to get the hospitals to the table to think differently. I think it was what I talked about earlier. It's what's the business case? For some, it's going to be the mission. For Nemours, it's the mission. For Wake Forest, it's the mission, right? But for others, it's something else. And so we've got to figure out what those things are. But I think what applies to everybody is this alignment between population health initiatives and the payment system. And we didn't really talk about different payment alternatives today. And I'm not just saying full capitation, but I do think that has to be aligned in order to get to get all the hospitals engaged.
Right. Judy?
Yeah, I wanted to add on to Jose's in this as well. I was really struck when Jeff said imposing order on chaos. And when I heard that, what my mind goes to is bringing order to chaos. I think of preparedness and the lessons that public health learned around preparedness. And to bring order to chaos is a leadership role. But there may be some lessons from the last 10 years or since 9/11 that public health has learned with working with partners. I mean, we did bring hospitals to the forefront. When we started working with and bringing folks in that had military experience, that's when we really got our act together around S&S and so forth at the state. So there might be some lessons from that history that might apply here. It'd be obviously maybe different partners and roles, but
I think that's a good comment. Certainly, there may be lessons in terms of the military's 4 aims rather than 3 in terms of force readiness, and maybe that is an equivalent to this life-ready 18-year-old that you were talking about in some ways. Now, let me ask the staff, are there comments from the web or a way that I should be asking for public comment beyond the room? Okay, so we don't have any comments from the web. Do you have any other comments to make?
I just have a question for Rob since he's here with us. So I think you said that you would know how to work with public health, but you might know how to work with the CDFI, I presume. So, I guess not, huh? I'm thinking from your perspective, tell me what you need. What do you need? Yeah.
Just ask Rick, whom I will spend a whole lot more time on because he's worked. The public health community is completely familiar to Rick, and he, through the hospitals and actuary, all of that, insurance, that's part of his milieu. For me, if I go to Danville, Virginia, and try to set up a early health pay for success project, somewhere along the line, maybe part of the Smart Beginnings project, that coalition involves the public health officer from that region. I'm so unfamiliar with what you do that I don't know whether you're organized by cities, by counties, or how it's done.
All of the above.
Say, okay, there you are. But I don't think that, I don't want to delay. I think you've got adjournment clearly at the front and center. I have some homework to do, but I don't think it's anything we need to deal with at this point. So thank you very much.
Well, thank you very much. Any concluding comment, David, before I wrap up? Okay. Well, and it's just to me to say thank you for everybody. I want to thank you again to the leadership, Terry and the Planning Committee, the IOM staff, but thank you all to the roundtable members for your great questions and participation, and especially thank you to the guests that we've had, the presenters who prepared and have made this a very, very rich discussion for us. So thank you, and we stand adjourned. Good day. Outstanding.